I'm not an interventionist at all. Actually, I come from basic science. And, but I was asked to make some comments, and actually in the institute where I'm working, my colleagues are doing some research on bioabsorbable stents. So I thought that I could try to tell you my opinion. Well, first of all, revascularization. I told you that this was one of the good ideas which has contributed tremendously to the 7 years increase in mortality that cardiology has provided. And it is a very short story because, you know, in 1964, the first CABG, in 1977, the first coronary angiography, 1984, the first coronary stenting, and today we are talking about bioresorbable stents. That is, to me, amazing. Equally is amazing when they explain to me what a bioresorbable stent, or BVS, is. Because the difference is that this stent here is made with metal, and this one here is made with plastic, actually by this polylactate acid. And literally speaking, is made of the plastic that we are using for shopping. Isn't that amazing, the technology? I mean, for me, it's really incredible. And you have these crystalline regions here, which is parallel lines, and these amorphous regions, which is keeping the stent together. And what is happening is that the amorphous region start to be utilized, actually, by the body. I will show you why. And then all these laminar regions will slowly disappear. And lactic acid is a substrate for the heart. Isn't that amazing? Lactic acid is a free carbon atoms molecule which is produced during anaerobic metabolism, but which is used every time that we are doing an exercise and so on. And so by doing exercise, in 2 or 3 years, we can reabsorb completely this stent by using the Krebs cycle. And actually, we are producing a little bit of ATP by the Krebs cycle, by dissolving this stent. So I think that the technology here is really amazing. But we should not be impressed by the technology, we should use the technology. And so, which is the rationale of using these stents, which are also more expensive? Well, the first strong rationale is that there is a better recovery of the vascular function. And we were talking about life and death of the endothelium. Imagine how the endothelium enjoys a piece of metal, stretching it and all his endothelial cells and so on. God knows which kind of death will occur at that particular level. Also, you should have no late chronic inflammation. You will allow the possible future surgical intervention and perhaps a better quality of life. So there is a good rationale for this BVS stent. But what we know today about the BVS stent? Certainly not enough. There are some trials, but these trials are performed with only one typology, the bioabsorb BVS stent. In elective patients, the trials has been conducted in patients without complex lesion. The initial endpoints, only now we are starting to have clinical endpoints. They were functional and angiographic endpoints, and also the number of patients studied is rather limited, although is improving. because when you put together all the absorbed trial, by the end of this year, we should have 16,000 patients studied. And that is something important. These are the studies which has been conducted so far. As you can see, the population was very stable coronary artery disease. Acute myocardial infarction was an exclusion criteria. These were the comparators, mainly the science stent, and these were the endpoint. Only in the absorb-free we have a real clinical endpoint. What the trials tell us? They show comparable result to death in simple lesions and in stable patients. That's good. But in real life, we know that normally patients are not very stable. Often they have an acute coronary syndrome, and often they have complex lesions. And our host has already shown that to us. And therefore, it is better, instead of looking into the trials, to look into the real-life registries or the observational research. And if you do that, and if you compare the rate of stent thrombosis with the BVUS, with the other typology of stent, then you can see that with BVUS, you have more stent thrombosis. And that is the major concern as per today. Why you should have more thrombosis? Because of what our host has just told us. Because you need to be very accurate when you are using these stents. You need to estimate very accurately the dimension of the vessel. You need to be accurate in the pre and in the post dilatation, and you need to use, I should say, pre and post intracoronary imaging, mainly the OCT. So this is at the moment the limit of using this stent, which should be used in hand of people who know what they are doing. It's not something for everybody. What the recent data are telling us, and there are some recent trials. One is the Trophy trial, which was also presented in London, and it was compare the absorbed stent in a few number of patients with the science expedition, again, few number of patients. The endpoint was a sort of a score which has been created and which has been looked at 6 months. And this score was looking at the number of not colored, but covered struts. And it seems that the two type of stents produce more or less the same effect in terms of angiographic endpoint. And there was, at the end of 6 months, no real difference. Then the ABSORB2, which was again a trial with a few numbers, and there was no real difference between the ABSORB and science. But if you look carefully, there was more percentage of myocardial infarction, slightly more cardiac death. Of course, none of this is significant, but this is telling us that here you have a lot of expertise, here you need to make some kind of expertise. And eventually the ABSORB-free, which is the one looking at clinical criteria as an endpoint. Here you have the eligibility criteria. You can see patient with clear evidence of myocardial ischemia, but once again, with no elevation of CK, MB, or troponin, 1 or 2 de novo target lesion in 2 native coronary artery, but maximum you had to have 1 lesion per artery. The lesion has to be of not a big diameter, not a big length, and the endpoint was really a clinic one. As you can see, the design of the study was involving more patients, 1,300 in the AMSORB, and actually half in the science. And you can see that these were the non-inferiority limit for the primary endpoint, which was a composite of cardiovascular death, target vessel, scaffold thrombosis, target vessel revascularization, so clinical endpoint. And you can see that the boundary of non-inferiority was not overcome. Therefore, we can say that AMSORB-3 is telling us that BVS are comparable to science stents, and that is important. We will need to see whether there will be a better long-term effect. To visualize the BVS marker. And this is a particular problem when you have to use two stents in sequence, because you don't want to have long overlap between the stent, and you don't want to have a gap between the scaffolds. Because if you have one of these two, that means that you might have thrombosis. And because they are not really visible, one possible solution is to use the enhanced stent visualization, which is provided by the majority of the modern angiographic system. And that is what we are interested at the moment in Ferrari. And the best achievable overlap between two BVS is when you have a complete parallel marker-to-marker implantation. And when you have this, the overlap length is less than 1 millimeter. And basically, what you do, if this is the stent which is already implanted, he has these two markers here, you have to place the other stent, and you have to make sure that these 2 points here are really parallel to these two. But with the normal visualization, that is very difficult. You cannot really see well the overlap at all. If you use this increased methodology, which, as I said, is provided by the machine, then you can have a better or let's say a less overlap, because you see much better the two stents, and therefore you can enlarge the second one at the right position. What we have done a small study, and in conjunction with Carlo Di Mario in London. And in London, they did several cases with angiography-guided implantation, and we used the enhanced system implantation in Ferrari. And then we did OCT post-implantation in all the cases. And you can see the difference. This is the patients done in London. You can see that there is often a rather large overlap or a gap in red, which appears in some of the patients. You can see that there is significantly less overlap and also significantly less gap. So this seems to be a promising, very particular technique in order to use the BVS. And in conclusion, the role of BVS in coronary artery disease intervention is indeed very interesting, but I would say at the moment is limited. It is interesting because the procedure could be more physiological, and we are aiming to have more physiological procedures. Limited because the lack of data, only one of these stents is available today, maybe others are coming up, and by the need of very accurate learning curve. And that is really very, very important. It's not something that people should rush and do, simply because they will deprive the patients from the other stents. And this is quite an important issue. Thank you very much for your attention. Thank you.